The lady actually laughed at me. I told her I'm trying to access abortion, safe abortion. Then she laughed at me. She's like, you want to abort? I'm like, yeah. She's like, how many weeks are you? I said, 6. Do you have any children? I said, no. And then she's like, then why do you want to kill that one? The guy's like, the hospital does not offer abortion services because they're child friendly and my child could be the next president.
Are you considering an abortion? Where do you go if you want to terminate? Is abortion free in South Africa? And what are the reproductive rights of women? Why are women's reproductive health so important? Hello and welcome. I'm your host, Dr. Musamtomeni. Signing with us is Trifosa Ntsolengwe. And today in Vital Science, we focus on women's reproductive health and reproductive rights. Coming up on the program, we listen to an insert produced by Health E-News about how COVID-19 may have affected sexual reproductive health. And of course, the programs that come with it. We speak to the Chief Director of Women's Health, Maternal, as well as Reproductive Health at the National Department of Health, and we'll speak to the Senior Capacity Building and Policy Advisor for Sexual Reproductive Health as well. Zabuteleze is still in the building, and of course, she'll be taking us through the COVID-19 numbers, and Dr. Marla McKay will answer your questions about COVID-19, the symptoms, and everything vaccines. Remember that you can be part of the show by asking some of our guests some of your questions, and of course anything that's on your mind by simply sharing your views with us and anything that we're discussing. The number to call is 011-714-5861 or of course 5877. That's 011-714-5877. Of course, you can also find us on social media. That's where you can put your thoughts to us. It's at SABC Vital Science, as well as on Facebook. It's SABC Vital Science. Vital Science continues right after this ad break. Stay with us. Welcome back. This is Vital Science. I'm Dr. Musamtomeni, and we're about to meet Gaupalelwe Phalaitsile as she speaks about her life as a journalist, a feminist mommy, and an abortion activist, courtesy of Health E-News.
My name is Gaupalelwe Phalaitsile, also known as Feminist Mummy on Facebook, Twitter, and Instagram, and now on YouTube as well. I am from the Northwest, 40 minutes away from the Rustenburg town, from a small little village which is now a township called Munagato. I'm a journalist by profession, but I'm also a mom to 2 amazing little boys. I'm also a feminist with very, very strong views. When we talk about dismantling patriarchy and white supremacy, we're talking about getting everybody involved despite their gender. I've heard from other mothers who are raising girls about how scared they are about, them growing up and the fact that they can be exposed to violence. But I also have the same fears raising boys because we don't talk a lot about how boys are molested. We all know that boys don't talk and men don't talk about their abuse as children. So I think when it comes to raising children, all of them, it should be similar, it shouldn't be too different. It started in 2016 when I opened up on Facebook about having had an abortion, an illegal abortion. I think I'm at the place where I'm so comfortable with myself that I can share myself with the world. And yes, it's scary sometimes, it's challenging sometimes, and I need to know what of my kids to expose because they don't get to choose. So I'm very careful with it when it comes to them. The decision to start Abortion Support South Africa was basically based on the fact that South Africa, on a scale of 1 to 10 in terms of access to terminations and sexual and reproductive services, we are at a 3. Women aren't accessing facilities the way in which they need to because abortion is legal in this country, and that was the reason why we started the page and the support group. The journey has been difficult, but I'm very happy that women have this kind of space and anybody else who falls pregnant, because we do know now that not only women, can fall pregnant and need reproductive services. I do think that the decision to open up more facilities that offer second trimester abortions, or rather to perform more second trimester abortions is because of the fight that activists have put. From 2018, we had a campaign with Global Health Strategies on safe abortions. There's been a lot of work that has been done to force government to take this issue seriously. A lot of people did encounter problems in terms of accessing abortions during the lockdown. A lot of people were told, we're not doing this service right now because of coronavirus, and that was not true. Legally, abortion was still supposed to continue. I don't take the excuse that COVID-19 has delayed them making sure that the National Strategic Plan is implemented. The National Strategic Plan came about after the Gender Summit, which we demanded. And I think during COVID-19, the reports that gender-based violence have increased and all of that, they are all true, but that is also a sign that you can't use COVID-19 to delay dealing with gender-based violence. What COVID-19 has done is it's shown us how deeply entrenched the issues that we've been raising of inequality, gender-based violence, poverty, child hunger, child neglect and abuse, way more than we've ever seen them before.
After the ad break, we speak to Dr. Manala Makuwa, the Chief Director of Women's Maternal and Reproductive Health at the National Department of Health. Stay with us. Welcome back. This is Vital Signs. I'm Dr. Musam Tombeni, and today we're talking about sexual and reproductive health. So sexual and reproductive health rights for women are not adequate at healthcare facilities, and of course access to youth-friendly services is also hindered by resources and culture. While policies protect young women's sexual and reproductive health rights, most don't know their rights or struggle to access these services. Now, COVID-19 has also made it quite difficult for people to access these free services, and of course more information about sexual and reproductive health rights. We are joined by Dr. Manala Makuwa, who is the Chief Director of Women's Maternal and Reproductive Health Services. Good day, Doc. How are you?
I'm fine, thank you.
Very well, thanks. So let's jump right into it. When someone speaks about sexual reproductive health, what exactly are they talking about, especially in women?
The reproductive health is a broad, and it actually covers quite distinct areas, but they are interrelated at the end of it. So you're looking at sexual and reproductive health within a continuum of health, right from the delivery of a baby or a child, all the way to adulthood. So you're looking at issues around information when you're still young. It looks at what do you know about your sexuality, what your sexuality orientation is all about, and then it develops to puberty, where you start looking at, do you know the changes that are happening in your body? Do you know what to do with the emotions that are related to it? Do you know how to handle the physical changes that you are observing? And then it complicates when it gets to sexual active stage, where now you are driven by the hormones that try to have them eager to have sexual intercourse. That's where things got complicated, because now you need to know when to say no, when not to be dictated to by your body, and how to handle that. And that's where the whole issues of accessing sexual and reproductive health issues come in. That's where the use of contraceptives come in. That's where the issues of termination of pregnancy comes in. But again, it also goes beyond that. It also has a pleasure stage where you're now ready, you're planned, you understand, you're physically ready, and then you plan your pregnancy. Then from planning your pregnancy, you know you enjoy the baby that is being delivered, and then you also transition to parenthood. And so that's where you would have a full continuum of sexual and reproductive health. Not forgetting that there are things that may go wrong. You may develop some conditions. We have issues around the breast cancers, the cervical cancers. You've also mentioned some of the things where somebody starts dilating your rights, and then you get exposed to gender-based violence, and then the situation gets complicated. Your social factors, where the poverty issue comes in, the whole continuum brings together the concept of sexual and reproductive health. Thank you.
So in terms of all these rights, I mean, such a broad, discussion to have, but specifically for South African women, what are the important reproductive rights that, young women or people just across the spectrum need to be on the lookout for?
first thing is to know your body, know yourself, know the needs, and know how to respond. Let's take the young girls. Let's focus on the young girls who are between 10 and 14 years. What happens at that stage, they are at puberty. They are observing all the changes that are happening. The first right that they have is to get understanding of what is actually happening to them. Mm-hmm. And they need somebody who's going to take time, sit down with them, explain in the language that is understood by them, and repeat the same message over and over again. Because you don't tell it once and then it gets translated, because it manifests itself in different ways. So information becomes critical. Now the question is, who's supposed to give that information? Again, is a community responsibility. We can't shift the responsibility to health and start blaming the health sector to say the Department of Health did not give girls information. It also is the right of a parent to sit down their kids. I think the clip that we saw earlier on indicated that be it a girl, be it a boy, the risk is almost at the same level. You will quantify it in terms of digits, but however, the risk is a risk. And then you look at the role of all other adults, people living within the space of that young girl. It's the right to interact with the outside world with confidence, without being intimidated by the questions they ask, the answers they said they're supposed to get, and the response to the questions. Let me pause there.
So, I mean, you've touched on two important points that I've noted there. The first point is that, the education or the dissemination of information is important from two perspectives. Is that, of course, you want the department to do things and give out information so you could, outline what the department is doing there. But the important one that you've also mentioned is that the community and also parents are also and should be involved in the dissemination of this information as well. So in terms of both aspects, how can we improve the dissemination of this information?
Indicate that termination of urban pregnancy or sexual reproductive health rights or contraceptive access is not a health crisis. It's a symptom of a societal mental health space. Let me repeat it. The issue of around sexual and reproductive health is not a health crisis, but is a symptom that depicts the challenges within the societal space. The reason why I'm saying this is that when you give information, when you have a young person visiting the facility, he gets there on a Monday morning between 10 and 10:15, you say whatever that you say. And then somebody fills up the space between that time and the next time you meet the person. And who fills up that space? And what type of information are they saying? You want the young girls to start fantasizing about having kids, getting married, and confusing them with a lot of information, the peer pressure, and so many counter-information that is happening out there. So the key message here is message needs to be consistent across the board. Okay. So you don't want to confuse kids where they go to a health facility, we tell them about delay, the need to have a child, and then they get home, whoever is in the family space asks them, when are you actually going to have your kid? Because all your friends are having kids. So we need to be consistent and collaborate and make sure that the message we're sending out there is very clear. It's not yet time. You are not ready. It doesn't have the expiry date where you say, my time to have a baby has expired. You can still wait, but your time will come and then you can still have them. So that's the key information that we give. From the health, it will be the medical issues where we'll be dealing with scientific ways of explaining what contraceptive does, what termination of pregnancy does to your body and all that. However, the general message from the community today is not yet the right time for you. You can't be falling pregnant between the age of 10 and 14 years. It's so wrong.
So, I mean, you've just touched on an important bit, and I think it's time that we get into it, where the department has recently recorded over 23,000 teenage pregnancies, with about 934 of those girls being aged between the ages of 10 and 14, giving birth to these children. Of course, this obviously has an impact, but what are some of the things that, we as a society and the socioeconomic issues that we're dealing with, what contributes to these numbers being so high?
Let me touch on the issues on the numbers a bit. you are talking about 900 and something kids in Gauteng only.
Yes.
However, this is not the problem for Gauteng. It's actually the problem across the country. We have the numbers. The difference is that because of the high population in Gauteng, it looks like the 943 number is very high. But if you look at the percentage in every province as compared to the total number of deliveries, you will realize that actually the rural provinces are the ones who are getting more hit in terms of young girls falling pregnant at an early age. They may not be many in number when you count them, but in terms of the percentage, as a proportion related to those who are falling pregnant, the numbers are actually alarming. So that's one thing that we need to look into. But you also asked me about the factors that contribute to that. The quick things, there are one factor is the biomedical issues. The one biological medical issue that I'm going to talk about is the onset of puberty.
Okay.
About two decades ago, a 10-year-old girl will look like a child, will feel like a child, will act like a child. But now, 10-year-olds and 14-year-olds are confused. And it's even worse if you don't actually know the developmental stages. You see a 14-year-old already, the signs of puberty are manifesting themselves at best. She's got breasts, she's got bumps, she's got size, she's got sense of self, she's got all the signs of puberty. And when somebody looks at, and then she also starts behaving like that. When you look at the person, you're thinking she's actually matured. And because when you interact on a day-to-day, you don't request for verification, either ID document to check their age, you don't realize that you're actually dealing with a child. And those are some of the things that are misleading. There are many factors that contribute to that. And when that happens, then the hormonal stimulation starts taking place. They start menstruating at early age. You see the 10-year-olds start menstruating. And the fact is, the minute you start menstruating, then you know the chances of falling pregnant after having an unprotected sex. Actually, they are more than 50%. So you're likely to fall pregnant, irrespective of whether you're 10 years or not. So these are some of the issues that contribute to that. But again, there are social factors.
Okay.
But as we try to define the social space in different ways, the phenomenon that we are having is we're having our young girls not being supervised. They are not supervised when they're at home. They are not supervised when they are outside. They are not supervised in the school premises where they are, depending on the type of school that they're attending. If you're looking at boarding school, what is the level of supervision? I'm talking of outside the classroom setup. But you're looking at home, again, they're not supervised. They've got access to gadgets. They've got access to information that is not vetted. They can read, they can understand language, so they're not supervised as to what they're doing. But again, in a social space, they are also challenged by the risk out there. They are exposed to rape, they are exposed to drug abusers, they are also exposed to adoption and all sorts of things. So they are in a very volatile space. You keep them at home, you keep them busy with gadgets, they mislead them. They take them out, they go outside, they're at risk of being exposed to violence. They go to school, they are with peers. They are exposed to peer pressure. So those are all those things. If you bring them all together, actually they expose young girls to the risk of all these issues around the violation of sexual and reproductive health rights.
So, are there solutions to this? Because from, all the reasons and the ideas that you've put out as to why these young girls, these 10 to 14 or these teenagers, and we have such high numbers of them getting pregnant, sounds like a lot of it is dependent on the policing of young girls, where we're saying, get your body to not mature that quickly because, whether it is your peer or someone older will then take advantage of that fact and then get you pregnant. But surely this isn't the big issue. The big issue is the predatory behavior of either their peers or someone that is older that then gets them pregnant. So how are we solutioning this from a department's perspective to get these young girls protected, where we protect them from getting pregnant and not necessarily say that they must not get themselves pregnant?
Girls cannot get themselves pregnant. That is very clear and simple. The issue we're putting out there is that they are our valuable gadgets. We need to protect them as a society. And we cannot take that responsibility to one single person. The parents are doing their bit. teachers are doing their bit, the health systems is doing their bit, and many other sectors are doing their bit. Social development is coming into play. The police department, the justice, there's so many role players in trying to resolve the issue. But the common denominator is, are we seeing the young girls as our valuable assets to grow in a safe, protected, not fragile environment to become independent adults? So what I just want to bring into forth also is that we sometimes get into the concept that say, no, equip them to protect themselves from this. And if you look at the risk factors that I've mentioned, as young girls, even if we can give them information, even if we can give them what we think will equip them, but they still need protection from us not to fall into trouble. So that's very critical. So it needs a collaborative effort. Let each person who is a role player in protecting the young girls pull up their weight and help protect the young girls. From health department, I can tell you, there's one thing that we are being criticized for. We've opened the age, and we allow young girls as early as 12 years to access sexual and reproductive health services. And when we do that, we are being opposed to say you are actually exposing them to sexual behaviors. We are actually not. We are saying if they find themselves vulnerable, they need to know what to do, and then we'll take it from there.
Okay.
Let me pause there.
Thank you so much. I think we've covered a broad spectrum of the reasons why we find ourselves where we are, but also the kind of services that, young people or people just across the board can access these sexual reproductive health services. That was Dr. Manala Makua, the Chief Director of Women's Maternal and Reproductive Health Services at the National Department of Health. After the break, we speak to Dr. Mahwale Mogoentsho, the Senior Capacity Building and Policy Advisor for Sexual Reproductive Health. Stay with us. Abortion has been legal in South Africa since the enactment of the 1996 Choice of Termination of Pregnancy Act, but unsafe abortion is prevalent and particularly impacts poorer women and girls who are living in rural areas. In 2012, nearly 50% of adolescent abortions occurred outside of the clinical setting. Most were likely unsafe. IPAS South Africa partners with health departments in two provinces, Gauteng and Limpopo, to increase women's access to safe, high-quality abortions. Programs include training safe abortion providers and clinic staff and supporting facilities to provide safe abortion services. We are now joined by Dr. Mahwale Mogoentsho, who is a Senior Capacity Building and Policy Advisor for Sexual Reproductive Health and Contraceptive and Abortion Care Consultant at IPAS South Africa. Good day, Doc. How are you?
I'm doing well, and how are you, Dr. Mtomeni?
I am well on my end as well. I can see you're very excited about the chat that we're about to have. I'm just as excited because it's so important that, when you look at when we got, this passed, where it was a law, 1996, and where we are so many years later, yet we have so many people complaining about the same issues all the time and still going to illegal abortion providers. I just want to know where you think we've gone wrong in this sense.
I think... First and foremost, we needed to make communities aware of the importance of women accessing safe sexual and reproductive health and care, as Dr. Manana has alluded to. And I also think because of our cultural background with various beliefs and religious background, we kind of bar women and girls from accessing safe sexual and reproductive health and care, including abortion.
Okay, so could you kindly tell us about the work that you do in sexual reproductive health?
I happen to be working for an NGO, non-profit making organization called IPAS.
Okay.
And IPAS focuses on expanding the reproductive needs of women and girls and make sure that no woman dies because of lack of access to sexual and reproductive health and rights. IPAS has since signed a memorandum of understanding with the National Department of Health. Therefore, we collaborate both with the NDOH, with the 4 provinces rather, to render sexual and reproductive health and rights. The latest program that IPAS birthed in collaboration with National Department of Health as a response to the COVID-19 global pandemic is the public-private partnership program. This PPP focuses on expanding access to safe, quality contraceptives care to both women and girls who are afraid to access public facilities due to fear of contracting COVID-19.
Okay. Okay, so I mean, you speak about COVID-19 and we know the impact that it's had, you know, and one of the things and one of the discussions that a lot of people are having, especially with the statistic that came out a few weeks ago with those young girls who had, you know, fallen pregnant and given birth to all the children, is that it played an important role in getting those numbers so high. Do you think this is true?
I think in a way, yes, it is true, even though there were still social ills in the community that were perpetuated by the COVID-19 pandemic. And if I may go back to the private-public partnership program that IPAS, in collaboration with NDOH and the 4 provinces, are implementing to create extra access points for safe contraceptives and abortion services for women and girls. IPAS then, with the assistance or collaboration of provinces and districts, identify the private healthcare providers who are keen to be part of the LAC PPP project and went into signing of SLAs, service level agreements, and trained this identified willing public-private providers on the 4 modules of the National Sexual and Reproductive Health and Rights integrated curriculum. One of the modules, of course, being contraceptives, and the other one being safe abortion services and post-abortion services, including gender-based violence service.
Okay.
The first module focuses on what Dr. Makua was alluding to, which is sexual and reproductive health policies and rights, and it's a cross-cutting module.
Okay.
So after training these providers in collaboration with NDOH and other strategic partners, the providers were then ready to create access in their private facilities for women and girls to access contraceptive services. And APA's role and the provincial manager's role was to ascertain that the private providers that were trained were then affording the women and girls quality service on abortion and contraceptive services. The initial model of this exciting PPP program was for IPAS to purchase the LAC consumables. LAC, I'm referring to long-acting reversible contraceptive methods.
Okay.
An example being intrauterine device, what is commonly known as loop, or implanon, subdermal implanon, because subdermal implanon can be removed in 3 years' time, hence it's long-acting, and the IUD, which of course is commonly known as loop, is removed after 3 years. So women and girls would then have access to that long-acting reversible contraceptive methods. With the support of the provinces and the district, IPAS in the first model continue to purchase this IUD and intrauterine device and Implanon, and gave those consumables to the private providers, and even paid the private providers an admin fee, so that the private providers would then give the services to eligible women and girls free of charge. And of course, that was done in both Gauteng and Limpopo. We have since expanded this exciting public-private partnership program to 2 additional provinces, being Gauteng, Free State, and Northern Cape.
Okay.
And the new model is now for the district and the provinces to sign service level agreements with the private providers, and in the process train them on district health information system, and set within the SLAs an accepted nominal standard fee for women and girls to pay for the loop and the
Implanon, yeah.
And the Implanon, roughly 300 rands.
Sure.
We're also giving back the responsibility and authority to women and girls to take charge of their lives by paying that nominal fee. This, of course, also says that women and girls who are unable to then access this service from private facilities still have a chance of going to public health services, where the service is, of course, free of charge. This is exciting, expanding access to several access points for both women and girls.
It's very exciting.
To prevent unwanted pregnancy. And if I may just tell you that for now, we have reached 2,800 women.
Sure.
With this program.
Look, it's a very exciting program, and it gives me so much joy to think that, people that are in these rural areas, or people that just are scared to go to a facility where, you may find your aunt works there, or someone that knows a family member, makes it difficult for you to access those health services. And I think it's very important to have services like this. But I think let's take a step back a little bit. I mean, we've spoken about contraceptives. You've said quite a lot about it. And we've, spoken also and touched on issues of termination of pregnancy. But for a young person sitting at home who is a number of weeks pregnant and wants to terminate, what are the current, rules? What are the current numbers that the person needs to know with regards to how they can access these termination services? So when can they go? Is it, before they're 16 weeks? Is it after 20 weeks? What are these numbers?
Oh, very good. A very good question. And the answer to this question will, of course, be based on the Choice on Termination of Pregnancy Act, as you indicated, that the Act was passed in 1996. And as Dr. Makua had indicated, that we now have clinical guidelines for the implementation of the Choice on Termination of Pregnancy Act of 1996. So the circumstances and conditions under which pregnancy is terminated are as follows. First and foremost, when the woman is 12 weeks and 6 days, this woman, by the way, I'm referring to a female person of any age. This is how the Act defines a woman. So the woman can then access termination of pregnancy from public health sectors and, of course, private sectors, depending on her choice. And pregnancy will be terminated by a trained medical practitioner, who is a doctor, by a trained registered nurse, and also a trained midwife. The woman will then be offered termination of pregnancy after she has made an informed choice. And her request, the reason for requesting is not required. Any reason, as long as that reason is valid to the woman, then the service providers in appropriate designated health facilities will provide the service. Let me stop and remind the women that the registered nurses, registered midwives, and trained doctors are only available in public health institutions and private sectors. We plead with our women not to utilize the services of unscrupulous providers because these unscrupulous providers are not trained and therefore do not respect the rights of women to access safe abortion care. That was during the first 12 weeks.
Yes.
I'll pause for more questions and I'll continue.
Yes, Doc. So for the last, so anyone over 12 weeks, very quickly, how do they, how does it work for them? Very, very quickly.
Very, very quickly, from 13 weeks to 20 weeks, 6 days, the service is still provided by trained medical practitioners. But there are 4 indications for this pregnancy to be terminated. One of them being that if the woman continues with this pregnancy, it would pose a risk of injury to her physical or mental health. Number 2, that there's substantial risk that the fetus would suffer from physical or mental abnormality.
Okay.
The third one, that is as a result of rape or incest. The last one is is going to significantly affect the woman's socio-economic status.
Okay. And then post 20 weeks and 6 days?
Post 20 weeks and 6 days, there's also 20 weeks after 20 weeks and 6 days. Again, this is provided by a registered and trained medical practitioner. And this trained medical practitioner wouldn't just terminate the pregnancy without consulting with a registered midwife or a registered nurse or another medical practitioner. And in this instance, there will be 3 indications for the pregnancy to be terminated.
Yes.
One of them is if it endangers the woman's life, or number 2, if there's severe malformations of the fetus.
Okay.
Number 3, if it poses a risk or injury to the fetus. As you can see, from 13 weeks to outside the 20 weeks, there are reasons that are stipulated,
yes,
circumstances rather, that are stipulated. But from 0 to 12 weeks and few days, a woman's request is considered sufficient.
Thank you so much, Doc. What an insightful session that you've just given us, giving us all this information and, of course, telling us about the increase of services and the access to these services and what people can do. Go out, get this information, get your nearest provider. That was Dr. Mahwale Mahuinchu, the Senior Capacity Building and Policy Advisor of Sexual Reproductive Health. After the break, Zama Butelezi will take us through the latest South African COVID-19 numbers.
Very good morning to Vital Science viewers. I'm Zama Butelezi. According to reports, South African scientists have identified a new coronavirus variant that has a concerning number of mutations. Even though this C12 variant has been detected across the majority of provinces in South Africa, experts say that there is no need for panic, saying while it might be able to partially evade the immune response, vaccines will still offer high levels of protection against hospitalizations and deaths. This has to be combined with all the other public health and social measures. For now, though, let's take a look at the national COVID-19 statistics. To date, over 16.5 million tests have been processed in South Africa. Over 2.7 million positive cases have been recorded. Over 2.5 million people have recovered, but sadly, more than 80,000 people have died from COVID-related illnesses, and we are sending our sincere condolences to their families. More than 13 million people have received the COVID-19 vaccine jab in the country. So what's happening in the provinces? According to reports, there is a decrease in the 7-day moving average daily number of cases across provinces of the country, but numbers of new daily infections is not stable. We have seen it going up and down. Gauteng remains the epicenter of the third wave of the pandemic, with a huge drop in daily infections compared to KwaZulu-Natal, the Western Cape and the Eastern Cape provinces, where majority of new cases lately come from. For now, though, let's take a look at the infection numbers recorded in the provinces with big metros. Since the first case was reported early last year, over 900,000 positive cases have been recorded in Gauteng. Lately, this province is recording the lowest numbers of new infections. Close to 500,000 positive cases have been recorded in the Western Cape. This province is seeing a surge in new infections. Close to 500,000 positive cases have been recorded in KwaZulu-Natal. This province is leading with new infections. Close to 300,000 positive cases have been recorded in the Eastern Cape. This province is also seeing a surge in new infections. It is expected that new variants will continue to emerge wherever the virus is spreading. We are all reminded that vaccination remains critical to protect those in our communities at high risk of hospitalizations and deaths, and also to reduce the strain on the health system while helping to slow transmission. For now, though, let's take a look at the numbers recorded in the remaining provinces. Since the first case was recorded early last year, over 150,000 positive cases have been recorded in the Free State. Over 145,000 positive cases have been recorded in Mpumalanga. Over 140,000 positive cases have been recorded in the Northwest. Over 120,000 positive cases have been recorded in Limpopo. Over 82,000 positive cases have been recorded in the Northern Cape. Vaccine registration is still open for those ages 18 and over. You are all urged to register and go out there in numbers to vaccinate to lower COVID severity and hospitalizations. Let us continue to take precautionary measures, and these include regularly washing our hands with soap and water, sanitize using sanitizers containing 70% alcohol content, wear a cloth mask that covers both our nose and mouth even though you're vaccinated, practice social distancing and ensure proper ventilation indoors. Lastly, avoid mass gatherings at all costs. If you believe there is a chance you may be infected with the virus, call ahead to seek medical help from your healthcare provider or use the public hotline. Their number is 0800 029 999 and alert them to your symptoms. Remember to protect yourself, to protect others. Back to you, Musa.
Thank you so much, Zama. The numbers are looking, like you said, up and down. You know, one day you look at those numbers, you're like, 5,000.
You get excited.
Level 1, here we come.
7,000.
And then 17,000 the next.
Yeah, we need to be extra careful. Especially because we are told that the fourth wave is looming.
Yeah, the fourth wave is looming. Yeah, it gets scary. Every single time someone mentions a wave, you're just like, that time they've said, let's go to Durban and go surf on the waves. But let's leave that at that. Then we're going to end things off, of course, with chatting to Dr. Marlon McKay, who's going to answer some of those COVID-related questions and see how we can better equip ourselves with the right information so that we're not out there spreading fake news. Dr. Marlon McKay, how are you today?
Good, thanks, Doc. Thanks for having me again.
Good. So let's get into it. Flu season is technically over. Today is the 1st of September. A lot of people thinking, you know, spring is here. It's going to be warmer weather, so let's forget about it. But if you're someone that actually got flu, so, you know, you felt a little bit run down, went to go get tested, you were COVID negative, and you treated it as if it's flu, can you still go get your vaccine?
Yes, absolutely. If you've recovered and the symptoms have settled, it's imperative that you don't waste any time. As you've been mentioning, there's an impending wave coming. We don't know exactly when. The Pfizer vaccine will take at least almost 2 months until you're fully vaccinated. J&J at least 2 weeks. So time is of the essence. So the moment you feel better, zero symptoms, please get vaccinated.
So today on the show, we spoke about sexual reproductive health, and an alarming stat came out where a large number of women or young girls were falling pregnant. But let's talk about pregnancy in general. I think we've had this discussion before where the question becomes, if I am pregnant, can I get the vaccine? Should I get the vaccine? Is there information that says that the vaccine is safe? What is the answer here?
Yeah, absolutely. So there is very, very good data to show that the vaccine is safe in pregnancy. We also know that pregnancy acts as an additional comorbid condition. We know that with comorbid condition, there's an increased risk of severe illness, hospitalization, and death from COVID. So it is of necessity that if you are pregnant, that you do get the vaccine to protect yourself and to have a safer pregnancy. Initially, there was some debate about the timing, whether it should be in the first or second trimester, but I think the data again is very clear that the moment you find out that you are pregnant, it is again very important that you do get vaccinated.
So those are pregnant women. What about women that have just given birth and are lactating, breastfeeding their children? Should they go get the vaccine?
Again, very important data has shown that there's no issues with breastfeeding and the vaccine. So that peripartum, just postpartum period after pregnancy, again, high risk for severe COVID. Again, no problem with getting the vaccine at that time. Completely safe and urgently recommended as well.
Awesome. So we're going to look at some of the questions that come from our viewers. Celine Hudson saying that I had COVID about a month ago and I lost my taste and smell, which is yet to come back. Did anybody else experience a burning sensation in the nose? Does it stop or does it go away at all?
Yeah, so you get this a lot. There is this burning sensation. Also, we have patients that complain of phantom smells. They can smell as if there's smoke in the air or something. They're smelling something that is not there. For the burning sensation, we do recommend, please, after COVID, still continue with the steaming, even if it's just once a day. Get that nose nice and moist, drink lots of fluids. Sometimes you also get a bit of acid reflux post-COVID. You may want to take something for that. The problem with all these questions, Doc, is that we can't give you a timeline as to when it's going to improve, get better, or just simply go away. So we urge you to please just be patient, stick to the basics, and things will improve.
So we've got another question from Tamira Hudson-Matthew saying that, hi everyone, I need some advice, please. My daughter had COVID pneumonia last year in December. 3 days ago, she went for the Pfizer vaccine. The following day until now, she's had chest pains, no shortness of breath. Has anyone felt this? And can I use it until I get the doctor in the morning?
Yeah, it's a very, very good question. Without causing too much alarm, there are simple side effects. You can get chest pain, headache, body aches and pains. However, there are few reported cases of some inflammation of the membranes around the heart, especially post the Pfizer vaccine. I would just recommend some paracetamol and a mild anti-inflammatory like betaprofen. If it still persists within the next few days, then maybe go to your doctor. As I said, it could be just something extra, but it's not something that we can't deal with.
Another question from Lucky Kasela saying that tingling pain needles, as well as on my hands and feet. Thigh feels cold. I breathe weakly, feeling unbalanced when I'm standing, even when I'm walking. What can I do with this problem? And I'm also worse is that I'm losing weight.
Yeah, so the first bunch of symptoms indicate what we call neuropathic symptoms, which means that the nerve is either inflamed, irritated, pinched. So that can be a little more challenging. What worries me more than anything is unexplained loss of weight. And that's usually a little more serious. And around COVID, post-COVID, during COVID, I would also be concerned about diabetes, the impact of COVID on sugar levels. And those could also be symptoms related to that. So the short answer, please get professional assistance. See your healthcare provider, a sugar test, check those nerves out and see what's going on there.
Okay. In another question, of course, a lot of people will say they've gotten their Pfizer jab and they've got, another appointment to go get their second jab. But in the time, they get COVID. And now the question is, when should they go for their second one? Do I need to wait a month or do I go on the scheduled date? Let's say it was in a few days' time after I've gotten COVID. When is the right time to go?
So the right time to go is if you've had a mild infection, no hospitalization, it's 30 days from the day that you were de-isolated. So that's after your 10 days of isolation, count 30 days forward. That will usually be just slightly beyond the date that you would have been given had you not got COVID. So remember that COVID takes priority and therefore you count that date. Please do not go before the usual date that you would have had. If you had been a more serious illness, hospitalized, then you must wait 90 days before going for your vaccination.
So who shouldn't vaccinate? I know it's a weird question to ask, but I'm sure there are groups where we say, yeah, listen, maybe take a breather, don't go as yet. So who shouldn't vaccinate?
Yeah, so who shouldn't vaccinate is basically those who are ill at the time, who strongly suggestive of COVID, have COVID symptoms, have any sort of pyrexial illness. And that's about all. And I think it's an important message that really everyone should vaccinate. In terms of allergies, there's, if you're allergic to something that's found in paint, propylene, ethanol, something. Otherwise, anyone can, whether you have comorbidities, it doesn't matter what medication, what conditions you have, you must vaccinate. I would just say, if you feel sick, if there's any suggestion that you've been exposed to COVID, have COVID, or any respiratory symptoms at that time, not a condition, a symptom, just delay the vaccine until you feel better and then you can go in.
Delay the vaccine. So very quickly, last question from Sandy Lezulu saying that, hello guys, has anyone experienced brain fog, but as a result of an itchy spine and slightly causing balance and coordination issues?
Yeah, so brain fog is probably one of the most common post-COVID symptoms. However, it's just that it's fatigue, you can't remember, you're battling with focus. Once you're getting something more, something more serious in the spine, I would be concerned. That is not brain fog. That is a spinal condition and may need warrant further investigation or at least a visit. But brain fog by itself, very common. And we can't be too sure how long it lasts, but it will get better.
All right. Thank you so much, Dr. Marlon McKay, for joining us again today to have discussions around COVID and all the questions that people may have at home with all the little things that happen to them that they're either too scared to go see a doctor about or just a little bit worried and just want a little bit of information. And of course, Dr. Marlon will join us again very soon. It's time for us to say goodbye now. Thank you so much for all of our guests that came through and joined us as, we answered some of the questions that you had, and we had this discussion around sexual reproductive health and, of course, women's health. Don't forget that the only way to manage this pandemic is to play it safe. Let's protect each other. Let's get the jab. Let's stay at home. Let's social distance. Let's keep those hands clean. And of course, let's wear a mask. I'm Dr. Mosamtomeni. Do take care.